Good morning, everyone, and welcome to HealthRecon Connect's webinar on infectious disease and MolDX Z Code. I'm Linda Protopappas, and I'm the Executive Vice President of Sales. I also want to, this morning you'll be learning about who is impacted by the new changes. After April 17th, is ID testing dead? What type of test can I be paid for? Do I need to get a MolDX Z Code? And how much can I expect to be paid? To walk you through these, it is our honor to introduce you to our Director of Laboratory Services Support at HealthRecon Connect, Mr. William Baus. William has over 15 years experience in HealthRecon revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management, building onshore, offshore, and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories as the Internal Revenue Cycle Director with preview over every step in revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to all of our attendees. If you would like to ask a question, you may do so by sharing your questions via the chat box or raising your hand, upon which one of our team members will enable your video. Following the conclusion of the webinar, please take a few minutes of your time to fill out a short survey. Let us know what you liked about the webinar, how we can improve, and what other topics you would be interested in for our future webinars. As a reminder, the recording of this webinar will be published on our social media in just a few days. And also remember that I will be sending out personally an email of the presentation and the webinar. William, it's all yours now. Thank you so much for attending.
Thank you, Linda. Thank you. And thank you, everyone, for joining HealthRecon Connect, the leading revenue cycle management company for laboratories focused on compliant yet maximized reimbursement. And today we are excited to share with you the changes in infectious disease syndromic panels. And so let's get started. So who's affected, who's not affected? When did this happen? What is affected? Do I need a Z code? What is a DEX Z code? And what is this MolDX program? And what is my reimbursement range are the focus of our topics. Disclaimer that because we're going to be speaking about things in generalities, taking any information utilized or gained from this webinar and applying it on your own without guidance could lead to unpredictable outcomes. And so there's no acceptance of liability for lack of payment or recoupment of payment or loss of opportunity because of anything you use from this webinar without working with us. All right, so the first thing is who's affected and who isn't. And so what you've got happening here is any of the MolDX MACs. Okay, so when I say the MolDX MACs, first I even have to tell you what a MAC is. These geographic jurisdictions in these different colors that you see here, these are Medicare administrative contractors. That's where the MAC comes from, that have been awarded geographic jurisdiction to process claims on behalf of the CMS. And so there can be variation, and often is variation from one MAC to another in relationship to their LCDs, which is a local coverage determination. And I think it's also important to note a few things about what we're looking at here. So the MolDX MACs are Palmetto, Noridian, WPS, and CGS. So Noridian here, Noridian actually has separate jurisdictions, and so they represent that by separate colors, but they're the same Medicare administrative contractor. So the Noridian accounts for all of this. WPS accounts for this. CGS and WPS is again over here, and then we've got CGS here. Palmetto is over here. So those are all of the MACs that utilize the MolDX program, and we'll discuss what that is in a few minutes. But it's, I think, enough to suffice to say, at least from a map perspective, if you're in any of those states that we just discussed, then these policies apply to you. And the MolDX MACs are basically operating in lockstep now. They're creating LCDs and billing and coding articles that are verbatim And by lockstep, I mean that they're being released at the same time now as well. So you can probably expect anything happening in Palmetto is going to be happening in Noridian in the future if we talk about other LCDs. So then who is not affected? Well, anybody in Novitas, which is basically Texas and the contiguous states in Colorado and Alabama, as well as Pennsylvania and the contiguous states there, and First Coast, which is basically Florida and the Virgin Islands. And then also anybody in NGS, which will be New York and everybody kind of northeast of that. And also over here right next to the Great Lakes, right? So those are the MACs not affected. And just as an aside, Novitas and First Coast are lockstep, same verbatim LCDs, and they're dropping at the same time now. And they actually do have two LCDs that are kind of related to what we're talking about, but they don't have the concept of the all-encompassing LCD that we're seeing for syndromic panels, which you can just think of that as not needing a separate LCD for a particular infectious disease panel. All right, so I think we've got that. And I wanted to just check in and see, do we have any questions about that? And I'm going to continue to do this throughout the presentation to incorporate questions to make sure we're all on the same page. Linda, do you see anybody with a raised hand or anybody have questions about that?
Not yet, William. I'll keep you posted.
Great, great. All right, then when does this happen? Well, this happens on April 17th. So it's a future effective date. I think it's an important thing to kind of bring up. An LCD goes through several steps in its evolution. And one of the steps is after the comment period closes, there's usually the minimum amount of time that they can implement that would be 45 days after the comment period closes. And that's why the future effective date is already set for April 17th. So it's going to be effective for dates of service on or after April 17th. And then I think it's important to bring up at this moment that a date of service is the date you actually collect the sample. There are a few caveats to that, but they are very specific instances and really are not to be used to fiddle with trying to change what your date of service was. Like, for example, a clever idea might be that, well, I'll take a sample on one date and run multiple panels, like in the concept of a reflex mechanism, which is inappropriate for the testing under this LCD. You wouldn't do that, and you wouldn't try, because I can't get paid for the same test on the same data service for the same condition, right? And so
William,
yes, ma'am.
William, so I have a participant that would like to know, is it 4/17/21 or 4/17/22?
That's a misnomer on my part. Very apologetic. It's this year. It is future for this April coming up for 2022. My mistake. And so the dates of service are then the date that the sample is collected, and you're not going to be able to get different samples paid for on the same data service by saying that you changed the data service because you ran the test again on another day, for example. Okay, so the next thing is, what tests are addressed under this LCD? Well, all of these tests that are covered are nucleic acid amplification tests. You'll see that abbreviated as NAAT or NAT sometimes. And what we're all very familiar with are, the PCR tests. Of course, that's in that test. And then there are a number of isothermal type tests that do amplification. And LAMP, I think, was a very common one we saw when COVID came out. And this may not be a complete list of all the NATs that there are out there, but if you have a nucleic acid amplification test and you're doing infectious disease, then it is covered by this policy. Then I think it's also maybe important to address what is not covered under this policy. And testing for over-the-counter at-home use antigen or antibody tests are not covered. NGS tests, not covered. Mass spectrometry, which is interesting. I was familiar with that from a toxicology perspective, LCMS, right? Half of it was mass spectrometry. But apparently there are people figuring out ways to use mass spectrometry for infectious disease testing, and it is not covered under the LCD that we're talking about today, nor is FISH. Now, this also doesn't mean that you don't have LCDs for that type of testing, and you very much do have LCDs for that. And the point is, what we're talking about today isn't related to that type of testing, even if it is related to infectious disease testing. Okay, so the biggest outcome for this LCD is whether or not you need a DEX code or FDA approval. And so I'm going to just briefly run through this and then give you a little bit of a diagram to kind of work this through, because it needs to sink in.
William, before you start that, we have a question from Dan. If you could just go to your Q&A, please.
If we send out samples to a reference lab and a non-MolDX MAC and bill as a send out, will it be covered? Okay, so if we send out samples to a reference lab and a non-MolDX MAC and bill, well, the answer to that question is going to take some of the steps that of understanding, but in general, here is the answer to that. If your test requires a Z code, the Z code needs to be the Z code from the lab that actually performed the sample. So in the instance where a Z code is required, and you send it to a lab that runs that sample, and they have a Z code, when you bill it, then you will use their Z code. And that will become more apparent why that is the case when we discuss Z codes, because effectively a Z code is a bunch of information about the test performed, like the methodology and the reagents and things like that. So when you're not the one who runs it, and if you need a Z code to bill that test, then the person who ran the test has to give you their Z code to use. So if they didn't have a Z code and you needed one to bill it, then you're not going to get paid. If they had a Z code and you needed a Z code to get paid, well, then you will get paid. And what I'm about to get into is there is some contention for certain tests, whether or not you need a Z code or not. For example, if the test was an FDA approved test and used consistent with the guidelines in the billing and coding article, then like you needed a diagnostic code and a CPT code, then you wouldn't have needed a Z code. So if they didn't have a Z code, that would be okay as long as they had run an FDA approved test like a BioFire test. So the answer to that question is a little bit more complex than you might like, but that will again come up throughout the conversation. So, and that is kind of what this slide is indicating is, for sure, if you have FDA approval and you use the ICD-10s and CPT codes that are listed in the billing and coding article, then you will get paid. But if you're not approved for FDA, there is a bit of contention about the Z code, and I'm going to point out what that contention is. But there is something that is very, very clear and will never change. If a panel is not in the LCD and billing and coding article, and it is not FDA approved, then it is a must that you will need a DEX code and a technical assessment. And I'm going to show you the workflow chart for that right now. So before we talk about the steps of this, and it basically boils down to two thoughts on this, is first of all, the LCD states it is a must to be FDA approved or cleared or have a Z code. And I'm going to take a moment to show you where that actually is said in the LCD. So the particular LCD I'm looking at right now happens to be the one for Palmetto, but these are verbatim for any of the MolDX MACs. And so those states that we just talked about are there. And you can see that I am talking about the notice period ending on the 16th, which makes it a future effective date on April 17th. So here's where it actually says this, right? Services that do not have FDA, Food and Drug Administrator cleared and approved indicated uses, as well as the test actually has to be performed in ways consistent with the intended labeling directions, which read what that means is the diagnostic codes. Guess where they came from? That's what's in our billing and coding article, right? So if you don't have FDA approval or cleared indicated uses, then you're going to need to get a Z code, register with the MolDX program, and get a technical assessment. And I'm going to define what all that stuff is. And then also, if you're not using the CPT codes in the billing and coding article, or you don't have an accompanying ICD-10 code, you would need also to register with the MolDX Z Code program and get a technical assessment to be able to show compliance with the LCD, and then therefore prove that you have been paid appropriately. Now, the billing and coding article actually contradicts that to a degree. It says that as long as you're using the CPT codes and the DX codes in the article, then you don't need a Z code. So let me show you that very quickly. So it says this on every group. So the way a billing and coding article works very quickly is there's some words that tell us things to do as billers and like what loops and wearing. It's very technical, not very interesting. And they'll give you some words, but mostly what they're doing is they're telling you if you're doing group 1 relates to the respiratory pathogen panels, and they're telling you these are the only CPT codes that they're going to pay for. And you'll notice these PLA codes, those are BioFire codes, which is an FDA approved test, right? So they would kind of know that you were using a BioFire approved FDA CPT code, in which case you don't need a Z code, right? Now, if you're using these other 3 codes, the way that the LCD reads is you would need, for your lab developed test, you would need it to either be FDA approved or you need a Z code. But then it says at the top of this, well, if you do use these codes, you don't need a Z code when billed with an accompanying appropriate ICD-10 code. I think this may be a misnomer. We have put in a question directly to the MolDX program citing this inconsistency, and we have not received back documented evidence one way or the other for the actual determination of it. My concern would be that in some instances, if you're not using a BioFire code, you would be using one of these codes for even another FDA approved test, so that Palmetto or Noridian or WPS, when they process this claim, they're technically not going to know if you're FDA approved or not. And so in an audit, maybe it would come up and they would bring up the LCD and say, well, you didn't have a Z code and you weren't FDA approved, and we paid you, but we shouldn't have paid you. That's what I'm worried about. Although it does seem to say here that, you know, as long as I use that code and of course one of the corresponding diagnostic codes that go with this group, then I would be able to get paid. And then I wanted to also make something very clear. That would only be under contention with something that is already in the billing and coding article. There are plenty of tests that are not in the billing and coding article, and I'm going to go over what those are, but first I wanted to show you the exact proof of that. I've had this conversation a couple of times, and it has come up that there's confusion about, well, maybe I don't need a Z code for anything, and I can just go off and bill whatever I was billing before, and let's let the cards fall where they may. And I think that's a horrible idea, and I want to prove to you why I think that's a horrible idea. Sorry, I had that set, but I was playing around with a couple of other quotes. Here we go. This article that I'm looking at, and I think maybe I should mention, there are 3 different articles that come with an LCD. First is the LCD itself, which is a bunch of words that give you a bunch of rationale for why they do or don't cover certain things, and a whole bunch of slew of rules that then basically get reduced into what I need to know from a billing perspective, telling me you need this diagnostic code, or you need 2 or 3 of these diagnostic codes, and the right kind of provider in ordering provider, and you need a diagnostic code or a certain CPT code, excuse me. Now, the third article that always comes out is the response to comments. Now, what that is, well, when they put out an LCD in its draft form, they allow people to read through that draft and make comments. So like the ACLA and AMA sometimes, and other big bodies will make comments and say, hey, there seems to be an inconsistency, or maybe you should add a diagnostic code. Or in this instance, the question was, hey, what is this stuff about needing an FDA or not, right? So this part here was the part I just showed you that is from the LCD. And the question was, hey, do I really need to have FDA approval? And this was the response here highlighted in blue. And the response is, hey, there's currently no FDA cleared or approved indicated uses for UTI panels. Nobody's even done that yet. And because of that, there's no predicate. Don't get worried about the word predicate. It just means that it's never been done before as far as the FDA is concerned. So as such, at present, molecular UTI panel tests must submit for a Z code and undergo a technical assessment in order to get paid. That's what the rest of that means. Now, what you could also extrapolate from that is if it's a test that is not in the billing and coding article, of which there are literally 5 tests, you'll see 7 groups, but there's really only 5 tests. It's RPP, GI, blood, the encephalitis one, and AGUG, which is anogenital and urogenital. And that's probably the closest one to what most people I'm familiar with when they do an STI panel would think of it as. Although the concept of doing lots of individualized tests for an STI without certain requirements has pretty much disappeared. And when it gets into question time, we can, if somebody's got real questions about that, we can dive into that. But what I'm trying to point out is something like nail, wound, UTI, and anything else that you would think of that could be an infectious disease syndromic collection of, why you would run a panel. If it's not in the billing and coding article, that means you don't have diagnostic codes. That means you don't have CPT codes already defined for you. That means you're going to need to get a Z code. And so some of the next stuff that we will talk about will be about that. But now I'd like to pause here for a moment, and I don't see anybody asking any new questions about this. I wanted to pause just for a second because usually that's a shocker to most people, that this would be, there would be such a requirement as this. And so the only real question I have is, if I'm using CPT codes and diagnostic codes for the 5 different kinds of tests that they cover in the billing and coding article, do I still need to get a Z code or not, is my question. But if you read what the LCD states, this is what it would work out to be. Is my test FDA approved or not? The answer to that is no, then I need to get a Z code. If my test is FDA approved is yes, well, then the next thing is I do need, whether I'm FDA approved or not, I am going to need to use one of the diagnostic codes as required by the LCD and listed in the billing and coding article. And I would have to use one of the CPT codes, or maybe more than one of the CPT codes as listed in the billing and coding article. And if I'm doing that, then no, a Z code would not be required, particularly in the instance of FDA approval. Now, if the answer to that's no, you got to go and get a Z code. So again, looking to see, I don't see any questions. Linda, you don't see any questions, right? Okay, I'm going to move on then. So, the next thing is—
William, you just got a question, please.
Okay, all right. If FDA test approved specific to the test or to the laboratory? Fantastic question. Our interpretation is that it is specific to the test at the laboratory. So your test will be a lab developed test and it needs to be approved. So just because someone else has been approved to do an RPP panel, for example, like BioFire or some others, that is definitely helpful to you because there is this concept of a predicate. But for you to have your test FDA approved, you have to go through and do that on your own. That is part of what I think is unclear about this LCD is, are they saying, well, if somebody else did it, does that apply to you? And my understanding of that would be no. You would still need to get your FDA approval, but your FDA approval is going to be much quicker when there is already a predicate, meaning you're going to be able to say, hey, I'm basically doing what BioFire did. There's 2 or 3 different pathogens in it, but here's what I'm doing. Because the other things that you described to them are not it's more than what you do for CLIA when you're doing your LDT, which is more concerned with the intellectual property of that, right? What is the FDA approval process? What is the link for the process for FDA approval? That I'm not prepared to get into, but we're going to take that down, and I'll try to find the link so that we can get that out when we send out our bodies. My understanding is from people I have discussed who have gone through the process, particularly the EUA process for some lateral flow devices, is that it takes a really long time. And it's interesting to note as well that there would have been predicates for the lateral flow rapid antigen kits that they were trying to get approved through EUA even, which is even less stringent than getting it approved or cleared from the FDA. And they're running on 2 years now. So it kind of seems in my mind, it seems like something like a BioFire is probably more geared up to do, like a manufacturer might be a little bit more, have more resources and that sort of thing to do that. So I'm thinking FDA is probably not your best approach. But again, I'm making comments that I'm not fully educated on the process. I've never walked a product through getting FDA approval. So my comments have limited, I think, usability for you. But what my understanding is, it takes a long time and it's very involved, and you would you'd probably be looking at a company that kind of makes the machines for that. That would be one to do that. But
William,
yes.
we do have one question from Samuel regarding the FDA approval process.
Yeah, that was just what I was talking about. I clicked over to that one. I actually have it up on my screen, which is, you probably couldn't see that. I think that's right. Yeah. So what would the FDA approval process is? What's the link for it? I don't have one right now, and I wasn't prepared to get into that, mostly because I thought nobody would even try to do it, right? Or that they would use like a BioFire's FDA approved test and run that test in their lab. All right, so that's that one. Okay, so now the next thing is we need to talk about what a DEX Z code is, what the MolDX program is, and they're not actually the same, but you will see some people call it a MolDX Z code. Sometimes you'll hear them just refer to it as a Z code. Sometimes you'll hear them talk about it as a DEX Z code. And I just kind of wanted to identify that these are actually two separate things, although they're both owned by Palmetto, and talk about that's got to be a conflict of interest somehow. But the point is, the MolDX program is the program that will access your Z code from the diagnostic exchange, which is what the DEX is. So the purpose of the MolDX program, it was originally created by McKesson in 2011. And the reason it was even created was under the understanding that the CPT codes don't clearly identify why something is or isn't paid for. And a payer doesn't know what they're paying for when you use some codes. Like, for example, if I show you what the initial CPT codes are. Linda, are you guys seeing this? I'm not just sharing my presentation. It does anything on that screen, right? I'm worried they can't see what I'm showing them.
No, we can see it.
Okay, so originally the MolDX program started out with molecular tier 1 codes, and notice how they're all in the 81,000 series. And then they went to the tier 2 codes, which were very appropriate to have a Z code for, because when you understand what a Z code is, it's actually telling them what instrumentation you use, what methodology you're using, you know, specificity, all the kind of stuff that you would document it from a validity perspective, as well as even the clinical validity and clinical utility perspective of what that test is that you were doing. And when you build an 81408 before, it was a whole mess of genes, and it could have been any one of those genes, and it could have been any target on any gene for any diagnostic purpose. And so they were just paying these codes, you know, without knowing what they were paying for. So a Z code lets you do that. That's what the MolDX program is doing, is it is utilizing this information to actually identify the test, determine coverage, and determine reimbursement. So there is one good thing about having a Z code, and it is they're not going to recoup money because they didn't understand what it was they were paying for. And that's another thing to understand about Medicare in general. They're pay and chase. And what that means is Medicare pays on good faith. This is why they get really upset when they find out later that they've been paying for stuff that they shouldn't have been paying for, because they make the assumption that when it's being billed to them, that it is being billed to them in a medically appropriate manner and is utilizing the right codes for the right tests. And when they find out that it's not, they take it personal almost, and they're really upset about it. So a Z code kind of ensures that that is not going on, and that may cause confusion. A lot of people automatically assume, oh, Medicare paid for what I did, that must mean it's right. And that's actually not right. Medicare, a lot of the times, is unaware of exactly what it's paying for and whether or not it meets medical necessity criteria, because there isn't enough information on the claim to determine that. A Z code solves that problem. That's what it is. So the MolDX Diagnostic Services Program means if you have a MAC that uses that, that means they're going to be looking for certain kinds of CPT codes. And when they see that, they're going to look to see if you've got a Z code. And if they've got that, they go to the DEX exchange and look it up. Let me show you very quickly what that looks like. So this is the Diagnostics Exchange Registry, and you will get a link to this. And what happens is you go in and you register a lab, and then you add your tests, and then they go through your scope of requirements, determine whether or not you need a technical assessment. And just in case you were wondering, if your test is not in the billing and coding article, you're going to need a technical assessment too. They've said that in the article multiple times and in the response to comments, and everything that I can figure out so far is that. Okay, so you go in here, you register your lab, you register your tests, and there's a whole process for doing that. And we'll give you this link for that as well. They give you an FAQ to tell you how to do it, and adding tests, and then there's a test lab worksheet. And I'm going to show you a little bit of that. Not that I'm going to try to explain to you how to use this. What I'm trying to point out to you is getting a Z code is a very involved process. Step one is the Z code. Step two is the technical assessment. And the technical assessment, I think, is even more brutal. And what I mean by that is, if you think this is going to be hard to do, getting your technical assessment approved is even going to be worse. So these are the kind of things so this is actually a spreadsheet that is showing the help file for when you're filling out your Z code. These are all the fields, right? Variants, mutations, alleles, the loci, mutation types. If you are FDA approved, it's going to help you out a lot, apparently, in getting it, because there's a lot of these, all the purple was about that. Then this red stuff are the different kinds of categories about what diseases and disorders and what's your methodology and medical supplies and FDA. And then here's where your billing company can help you out, right? We're going to be able to suggest what CPT codes you want, but you won't really know if those are the CPT codes you get to bill until after they give you your Z code. And we've said, hey, we want to build these CPT codes. They're going to say, yeah, I know you wanted to do that, but here's the CPT code we're going to let you use. And it might just be one. It kind of depends on if there's a bundled code or not, right? But you really won't know what CPT code you're going to be able to bill until then. But once you've done that, you're not going to have to worry that the wrong CPT code was billed and they're going to claw back for something like that, right? And then the more advanced stuff, some of it's optional, some of it will be required, some of it's only for the technical assessment, but it's the kind of stuff I think I remember seeing when people were doing their CLIA stuff, right? It's, what's the comparable test or assay? That's validation, right? What's your algorithm, your specimen information, your handling instructions, your turnaround times. Now we get into clinical validity. And then analytical sensitivity and specificity and predictive values and negative predictive values. Okay, all of that stuff. Now, then you get to your technical assessment, and it goes over clinical validity again and clinical utility. And clinical utility is going to be a tough nut to crack, because you're going to have to basically prove to Medicare not only that your test was a valid test, right? That's the clinical validity, but that what are the indications for when it should be used? And the indications read diagnostic codes. And then you're going to be looking around for that stuff. You're going to need to incorporate clinical people into devising that. You're going to have to find clinical studies and trials that prove positive outcomes for patients because of this testing. And I'm certain that there is for UTI. I've had this discussion with a couple of different people, and it's out there, but that's a very involved process, right? And so I don't see that happening very quickly. That's another question. So how long does it take to get this kind of stuff done? How long does it take to get a Z code? Well, they say on their website it takes 45 days. When they're talking about 45 days, they're not talking about the time it took you to fill out all that stuff we just got done looking at. They're assuming that after you've done all of that, they'll take 45 days and then respond to you. And it may also be a response at that point that, oh, by the way, now you need to do your technical assessment. And what I'm saying is I'm 99% sure you've also got to do a TNA even on a UTI because they explicitly stated that you had to, right? Now, you might not need to do a technical assessment when you're getting a Z code for your lab developed RPP test, because there will have been predicates for it where it's already happened before. And they're not going to be asking you questions about, is it a valid test to even do for respiratory pathogens? And they're not going to be asking you what the clinical utility is, because they've already made up their mind. That's what's already in the billing and coding article. So if you went and got a Z code for anything that's already in the billing and coding article, it's probably going to happen more quickly than for something that is not in the article, like the UTI, like wound, and like nail. Oh, and I think it would also be good to mention too, at the bottom of the LCD, it actually states that the panel, the group of doctors that created the LCD for the MolDX program that is being utilized by your Medicare administrative contractor, they actually said, and I'm going to mispronounce the word, it's onchiomycosis or mitosis or something like that. That means fungal, right? And they said, look, fungal testing under PCR is not medically necessary. So I probably wouldn't focus on trying to get nail done first, is what I'm saying. So let's pause there. Do we have any questions about that? I think I see one. FDA, okay, so if I am in a MAC First Coast and don't need a Z code, should I still start the process? So yes, very good question. If you're in First Coast, Novitas, or NGS, National Government Services, not to be confused with Next Generation Sequencing, but if you're in any of those, any of the states in those MACs, and you know what, I'll go back to that real quick. Sorry, makes it a little difficult to jump around. There we go. So if you're here in Novitas here, or in Novitas here, or First Coast here, or NGS here, and where else are they? They're somewhere else, aren't they? NGS, where are they? Oh yeah, up here in New York and North, right? So if you're in any of those MACs, this LCD does not apply to you at all. But I kind of can read into that a little bit, because the question has come up more than once about, so what do I have to deal with in these other MACs? Well, right now, in all three MACs that we just discussed, Novitas and First Coast are verbatim and lockstep, and they have two policies. They have one for RPP, and they have one for GI. The GI policy lets you bill up to the bigger code. The RPP locks you down to the smallest code for RPP, the 8763, 3 to 5 targets. NGS has exactly the same policy. I'm not 100% sure it's verbatim, and it is not being dropped in lockstep, but it looks to me like they're just kind of copying whatever Novitas or First Coast does a couple months later. So what you then have is a glaring hole in their policies for UTI. You don't have one. You don't have any required diagnostic codes. They're not telling you what CPT codes to use. There's no explicit specific guidance. What I can say though is Novitas and First Coast are probably never going to adopt the MolDX program. That's why I went to such trouble to explain what the MolDX program was, because that's when you need a Z code, and your MAC would need to say, I want to use the MolDX program. which is basically tantamount to saying, hey, I don't know how to govern my own geographic region and I want your help to do that, which obviously some MACs have done. I suspect ownership in common, because there is ownership in common between Novitas and First Coast. For example, the same parent company that owns Novitas owns First Coast, also happens to own Florida Blue Cross Blue Shield as well. And what you're seeing is the ones that are doing it in lockstep probably have parent company ownership. Now, what that means to me is unlikely that Novitas, First Coast, or NGS will adopt the MolDX program. That doesn't prevent them from creating something else exactly like the MolDX program, but it would take years to be able to implement such a program. And I think we would be hearing about it. What they could do, though, is they could take some of the requirements that are in this LCD, such as requiring diagnostic codes, which is their go-to for certain kinds of CPT codes or certain kinds of testing. They could also do the thing where they've adopted some of the changes in the way that they're looking at paying based on who is ordering the test. So like, for example, right now in Novitas and First Coast and NGS, we're limited to having 87631, which is 3 to 5 pathogens. We don't even get a chance to bill the 3.2 or the 3.3. Well, you do have the chance to bill the 3.2 or the 3.3, which gets you another $200, $400, right? In the MolDX MACs, but there are some fairly stringent requirements. Like, you're going to need 3 diagnostic codes basically to get that one paid, right? And you're going to be talking about an immuno incompetent patient, I think, but that's all kind of sorted out for you in the diagnostic codes. And I actually do have a plan to get into that just a little bit, and then see if people want to talk about any one specific panel in particular. But let me get back to where we are. And do we have any other questions about that? Okay. Okay. Yeah. All right. So when you look at the billing and coding article, there are 7 panels that they discuss. Really, there's only 5 different kinds of testing going on here, because the first 2, oh, sorry, I can't touch it. I wanted to touch it. The first 2 here, targeted respiratory and gastrointestinal panels, right, are 5 pathogens or less. And basically, there's a whole bunch of words in the document that say a whole bunch of things, but effectively, it boils down to this. You're going to need a diagnostic code from the group that belongs to, group 1 is respiratory pathogen panels, right? And if you use one of those CPT codes, that means you're going to get paid $142.63. All of them are paid out at exactly the same dollar amount. So whatever you do, and you've got one diagnostic code, you're going to get paid for 5 pathogens. Now, there is an important thing to note in here. It is brought up by legal at times, and it is typically said like this: hey, if I'm running a really big panel and I deliver a bunch of results on a big panel, but the doctor only ordered a very small panel, like 5 pathogens, but I'm going to report on 25 pathogens, like that's a problem, because it could be considered an inducement to say to a doctor, hey, come and do testing with me, because I'm only going to charge you for 5 pathogens, and that means it's going to be lower cost, but I'm going to give you all the information about 20 pathogens. That is considered possibly an inducement, maybe even a kickback if you're doing that to get other business or other things. So there could be a legal problem with that. Normally, that's the case. But in this LCD, it explicitly states, hey, we recognize that there's a technical, I don't know if they use the word limitation, but there are technical reasons for why a lab has to run the same panel it runs every time, and that's okay in the context of this LCD. But what we're telling you in no uncertain terms is, if you only meet the requirements for me paying you for 5 pathogens, I don't care if you ran 25 pathogens. And what that boils down to is, if you wanted to get paid for the expanded pneumonia and respiratory pathogen panel, you would need an additional 2 diagnostic codes. So that's a total of 3 diagnostic codes. And all of the words that they talk about with immunocompetent versus immunocompromised and this condition or that condition, it all boils down to, did you get 2 of those diagnostic codes or not? If you did, plus you had the original diagnostic code that's more symptomatic in its demeanor, meaning, I can get paid on symptoms for 5 pathogens or less. I got to have real problems to get paid for the expanded panel, right? But if you had a diagnostic code from the same group that you could get paid for the 5 or less, plus 2 for the expanded panel, that's a total of 3. Well, then you'll get paid. Same thing exactly happens for you on the GI panel. Get me 1 from that first group for the 5 or less, and get me 2 from the expanded panel, which again goes into the immunocompromised type stuff, even transplant, right? Well, then I'll get paid, right? This meningoencephalitis panel and the bloodstream panel, I haven't really seen people really interested in talking about it. I have some slides prepared for that, but unless somebody asks a question, I didn't want to get into it, because I did want to get to the only other one that might have a lot of relationship to the women's health and the STI panels that I see very commonly developed as laboratory developed tests. And so the common concept of like doing a giant exploded test for a bunch of different pathogens disappears. The 262 is the BVAB panel for women's health. And when you start doing STIs and you don't have the concept of high risk sexual activity, which is actually codified as diagnostic codes. It's things like forced sexual encounter, things like that, right? If you had that, you're going to get paid for what you bill, but then they're going to limit us on the codes that we use. And they're making us use like a bundled code. So you kind of max out at maybe 3 units of 70, so maybe 210, if that's even appropriate. It might be as small as $70. And that's where I think, that kind of destroys most people's concept for an STI at the moment. I would start thinking of having chips that let me do 5 targets or less and somehow make that profitable. I mean, at $142, and a cost of $40, it might be okay. But an STI panel, unless we can get into the 200s, it might be difficult, even if you got the panel down to $40 to make that reasonable from a profitability standpoint. We recognize that. So I wanted to pause there. I mean, I have additional slides prepared to go into the very specific details of each one of these. And I can do that. There's only one more general conversation about this that I think might be important is, so
William,
in general,
why don't we have one question?
Oh, okay, great. Oh, there it is. I'm in Noridian MAC, which requires Z codes. Are they going to start requiring Z codes for the PCR that are in the LCD? Yes, yes, that is the case. So RPP, GI, UTI panels, it was our understanding that only genetic testing requires Z codes for our MAC. Well, okay, so as far as the concept of a Z code is related to anything that's called an MDT, and that's a molecular diagnostic test. Now, you are correct. Originally, the tests were limited to this series of CPT codes. And if you actually look at each one of you, including Noridian, you also have LCDs explicitly talking about what the MolDX program is. And if you go there right now, you're going to see that it is these codes here and some PLA codes. They haven't even updated that yet. But what is happening to you in this LCD is they are saying that for the 87,000 series codes, they're going to want you to have a Z code registered for your molecular panel. Now that breaks down into 2 things. At the beginning of this, I was pointing out that there is a bit of contention, and I'm just going to reiterate that part again because I may have gone over that a little bit too fast. So if your test is FDA approved, and you use diagnostic codes and CPT codes in the billing and coding article, then you don't need a C code. And so the only tests that are in the billing and coding article are RPP, GI, UG and AG, which is kind of like your STI, the meningoencephalitis, and a blood panel. That's it, right? There's 5 of them, right? RPP, GI, blood, meningio, UGA, AG, right? Yeah, so there's only 5 different kinds of tests. Now, if you're doing any other test that isn't on that LCD, 100% you have to have a Z code, because there is no FDA approval for them. And so now you need to get a Z code. Where the point of contention comes in is, it says in the billing and coding article, if I use a CPT code and a diagnostic code that's in the billing and coding article, then we don't need to have a Z code, which is contradictory to what the LCD actually states. And I pulled up those 2 different statements earlier to make that a point. And we have put in a question to the MolDX program to ask them for clarification on that. So the only other can that article be sent to the participants? Well, yes, we can send you the article, but remember, it's different articles for, well, I guess we can just send them all out, but then it's going to confuse everybody. Hold on, let me try to explain something. All right, so back to the MACs. There we go. So every MAC, Noridian, WPS, CGS, and Palmetto will have their own billing and coding article, but it is verbatim across all of these MolDX MACs. So the articles are different. And so I guess what we can do is put all 12 articles together, because there's 4 things. There's an LCD that looks like this. Actually, the LCD will look like this, and it starts off and I'll tell you. So at the top, it'll tell you this is related to Palmetto, and it'll tell you what states it's in. So I would need to do this for all 4 MACs, and that's not a big deal. I just thought it might confuse people if they get 4 of them and not know, but they'll all say the same things. The only difference is the ID for the article will be different. It will still say that on or after 4/17, right? It'll tell you when the notice period ended and started. Those are all the same. The words in the article will all be the same. But I also will need to give you a billing and coding article that runs through with you. What I've been kind of describing is you've got 7 groups, really only 5 tests. Group 1 and 2 are the same as group 6 and 7. It's the only difference is if you're talking about 5 or less or 6 or more pathogens, right? And it tells you the billing stuff, you know, and very specific things, right? And then the 3rd article will be the response to comments, where many of you may not have gotten to the point where you're going to have questions, because you might actually still be in shock and disbelief about some of the steps that are here. But as you ruminate on it, there will be questions that you have. And what you'll notice is you probably, not to be downgrading to anybody, but you probably won't have an original question, because there's a really long document where a lot of people asked a lot of questions about this. So your question will probably be in there, and I would look at that then as well. So you'll have 3 articles. Now, the only other really overarching thing is, so the next thing that people usually try to think through or work through in their mind about this would be, well, can I do multiple tests? And the answer to that is, in general, no, right? I can't get paid for the same indication on the same disease in less than 14 days, right? So things that are not covered, right? You can't do the test again to see if I'm still sick or not, right? That's not the test can't be getting performed as a test of cure. And I don't know why they need to write that down, because when you understand the billing and coding article, you need a diagnostic code to get it paid. And there's no diagnostic code that says, I'm just looking, right? And nobody ever pays for anything just to look. If they've got a different diagnostic code, well, then yeah, then you're not talking about the same indication, right? So if the patient has previously been tested with the same pathogens within 14 days, right? So if you're testing for the same thing within 14 days, the general answer is that's not covered. Unless, and then they give you this exception here, right? Repeat panel testing for the same clinical indication will only be covered if the first panel yielded a negative result and there is a high suspicion that there's a particular pathogen causing the symptoms and the patient's condition is not improving or is deteriorating, and it is one additional panel test may be covered between 1 and 14 days. So you notice they said between 1 and 14 days, not on the same day. Now, that's really important because from your perspective as a lab, it's not the same day if you run the test on another day, but that doesn't matter. Your date of service is the date you collect the sample. And they're talking about dates of service here, not the days that you run it. And I know this because this is how you bill a claim, and that's the date that goes down on a claim is the date of service, right? So I would need, you couldn't do an RPP panel of 5 pathogens and then get a negative result and then run it again on the next day and then expect to get paid for 2 RPP panels from the same sample that you collected because it'll be the same day that goes down on the claim form, okay? And that's why the data service thing was kind of important that I was talking about. But other than that, every other thing that you can see here on the screen, you know, immunocompetent patients, what does this mean? Let's talk a lot about that. And let's get a bunch of details about that. And let's talk about, you know, gastrointestinal panels. All of that stuff, all these words, they all get boiled down and reduced to this. If you're going to do 5 panel, if you're going to do a 5 panel RPP test, that means you're going to be doing group 1. And then that means you need a diagnostic code from group 1, which is down here lower in the article once you get to the diagnostic codes, right? And I'm trying to get there for you, but sorry, it's probably making everybody dizzy. All right, let's keep going. Modifiers. Okay. Man. All right, and so group 1 codes, there's 112 diagnostic codes. These are the diagnostic codes that will cover you for 5 pathogens or less. And there's a whole bunch of words about why this is or not, but you can kind of understand when you look at the diagnostic codes, it's like I have a cough, I have a fever, I've got symptoms, you know, related to certain viruses, what the suspicion is, right? They're all symptomatic, right? When I go to the final group and look at the very bottom of it, what I will see is it relates to all of the words that they said in the other one, that you have to have an immunocompromised patient, an immunocompromised patient for being able to get paid. And that's, there are diagnostic codes that give you that say that that's what's happening, right? That's how you get paid, right? So I see we're getting to the end of our time, and it looks like no other questions, but I'm here waiting for it. If anybody's got anything, we can do that. Linda, do you see anything?
I don't see any further questions, William. I'm going to do a last call for questions, and then we can close out the webinar.
Okay. Excellent.
No, I don't see any other questions. Ladies and gentlemen, thank you so much for attending our webinar. Again, as I stated earlier, before William started speaking, I will personally be sending out the information, William, that you're going to provide to me, as well as this presentation and then the video, just in case your colleagues did not attend today's video. Again, if you would like any other additional information, or if you'd like to speak to William, set some time up, you can respond to my email and I'll make sure that I send that along to William. Thank you so very much and have a great weekend, everyone.
Thank you.